Hi, I'm Dr. Jack West, and I'm an associate clinical professor in medical oncology at the City of Hope Comprehensive Cancer Center in the Los Angeles area. For patients with advanced non-small cell lung cancer and tumor PDL expression less than 1%, there's several options right now. For a few years, I would say the leading ones have been chemotherapy and immunotherapy concurrently. Specifically, I would consider the Keynote 189 trial to be a pace setter uh, for non-squamous histology, that is carbo and pemetrexed, or cis or carbo with pemetrexed and pembrolizumab, and Keynote 407 of carbo with a taxane, either standard paclitaxel or nab-paclitaxel with pembrolizumab. These have demonstrated clear, consistent benefits across the spectrum of PD-L1, from PD-L1 negative to PD-L1 low to PD-L1 high. Now, there's other chemoimmunotherapy combinations. The Empower 150 trial was with carbo and paclitaxel and bevacizumab and atezolizumab. That showed a benefit over chemo and bevacizumab without the atezolizumab. That was also in a non-squamous population, and that also showed a benefit in patients who were PD-L1 negative. There was also a trial of carboplatin with Abraxane, and that's Empower 130. That's carboplatin, Abraxane, and atezolizumab, and that's FDA approved. These are all variations on the theme of chemoimmunotherapy, and I would say that the most commonly used ones are the backbones, are the approach of Keynote 189 or Keynote 407. Now, in the last year or so, we've had a couple of additional options that are centered around nivolumab and ipilimumab, and this combination was FDA approved based on a survival benefit of nivo-ipi over chemotherapy alone. In patients, the approval was just for patients with PD-L1 of 1% or higher. The benefit was also seen in patients who are PD-L1 negative, but the approval hasn't been there. I would say it's still an option to consider, despite the lack of an approval. And at the same time, we have a more recent approval of the Checkmate 9LA protocol, which is a platinum doublet of any kind with nivo and ipi, the chemotherapy administered for just 2 cycles, and the nivo and ipi continuing longitudinally until progression. And so that approach is a challenge potentially, because you're talking about the side effects of platinum doublet chemotherapy and the potentially challenging side effects of a PD-L1 and a CTLA-4 inhibitor. So a lot of agents and potential toxicity there, but if you need a response quickly and then can discard the chemotherapy, that would be of some appeal. So all of these are options that I would consider to be better. In fact, they are all demonstrated as superior to chemotherapy alone. They have not been compared against each other, and it remains a judgment call whether people might prefer a nivo-ipi based approach or a chemo doublet with pembro or some other chemo-immuno approach. All options, and it's really at this point a dealer's choice unless or until we ever see comparative data between them.